Hello everyone. Today I will be speaking on retinoblastoma. This is a pretty common short note in your exams, so we will try to have a complete understanding of retinoblastoma. We will cover genetics, histopathology, clinical features, differentials, diagnosis and treatment. Retinoblastoma is the most common intraocular malignancy in children, with a reported incidence ranging from 1 in 15,000 to 1 in 18,000 live births. It is second only to uveal melanoma in the frequency of occurrence of malignant intraocular tumors. There is no racial or gender predisposition in the incidence of retinoblastoma. It is bilateral in about 25 to 35% of cases. The average age at diagnosis is 18 months. Unilateral cases are diagnosed at around 24 months. Bilateral cases are diagnosed before 12 months. Most cells comprising the tumor histologically resemble the cells of an undifferentiated retina of the embryo called retinoblasts. Coming to the genetics, out of the newly diagnosed cases of retinoblastoma, only 6% are familial, while 94% are sporadic. Bilateral retinoblastomas involve germinal mutations in all cases. Approximately 15% of unilateral sporadic retinoblastoma is caused by germinal mutations affecting only one eye, while the 85% are sporadic. RB gene has been identified as 14 band on the long arm of chromosome 13 and is an anti-oncogenic gene. So deletion of this protective gene by 2 mutations results in RB. Coming to histopathology. The tumor is composed of small basophilic cells with large hyperchromatic nuclei and scanty cytoplasm. Many retinoblastomas are undifferentiated, but varying degrees of differentiation are characterized by formation of Flexner Ventostiner rosettes, Homer-Wright rosettes, pseudo-rosettes and flurries. Flexner Ventostiner rosettes consist of columnar cells arranged around a central lumen. Homer-Wright rosettes consist of cells arranged around a central neuromuscular tangle. Pseudo-rosette refers to the arrangement of tumor cells around blood vessels. Flurries are clusters of cells with long cytoplasmic processes projecting through a fenestrating membrane resembling a bouquet of flowers. Coming to the clinical features, RB may present in variety of ways. Leukocoria is the most common presenting feature, followed by strabismus, painful blind eye and loss of vision. The clinical presentation of RB depends on the stage of the disease. The 4 stages are: stage 1 is the quiescent stage, stage 2 is glaucomatous stage, stage 3 is the stage of extraocular extension and stage 4 is the stage of metastasis. Early lesions appear as a translucent or white fluffy retinal mass. Moderately advanced lesions usually present with leukocoria due to the reflection of light by the white mass in the fundus. As the tumor grows further, 3 patterns are usually seen. First is endophytic, in which the tumor grows into the vitreous cavity. A yellow-white mass progressively fills the entire vitreous cavity and vitreous seeds occur. The retinal vessels are not seen on the tumor surface. In presence of calcification, it gives the typical cottage cheese appearance. Second type is the exophytic, in which the tumor grows towards the subretinal space. Retinal detachment usually occurs and retinal vessels are seen over the tumor. The third is the diffuse infiltrating tumor, in which the tumor diffusely involves the retina, causing just a placoid thickness of the retina and not a mass. This is generally seen in older children and usually there is a delay in the diagnosis. When retinoblastoma is left untreated, some patients present with pain, redness and watering as they develop glaucoma or intraocular inflammation. Advanced tumors manifest with proptosis secondary to optic nerve extension or orbital extension and ultimately leading to stage 4, that is the stage of systemic metastasis. The differentials of RB are congenital cataract, retinopathy of prematurity, toxocara granuloma, PHPV, retinal dysplasia, Coats disease, choroidal coloboma, retinal astrocytoma, incontinentia pigmenti and uveitis. We will see few of the differentials. Congenital cataract will obviously present with leukocoria. ROP, that is retinopathy of prematurity, in advanced stage causes retinal detachment and leukocoria, but there is obviously a history of prematurity. Toxocara endophthalmitis may cause a cyclitic membrane and a white pupil. In PHPV, that is persistent hypoplastic primary vitreous, also known as persistent fetal vasculature, the patient's classical presentation is that of leukocoria, microphthalmia and a cataract. Coats is almost always unilateral, more common in boys and tends to present later than RB. Coming to diagnosis. EUA or examination under anesthesia should be done for all clinically suspected patients. It should include fundus examination, measurement of IOP, that is intraocular pressure and corneal diameter. Plain X-ray orbit may show calcification in 75% cases. Ultrasound and CT are very useful in the diagnosis and lactic dehydrogenase levels in aqueous humor is raised. Ultrasonography, that is B-scan, shows a rounded or irregular intraocular mass with high internal reflectivity representing typical intralesional calcification. CT delineates extraocular extension and can detect an associated pinealoblastoma. Coming to treatment. The primary goal of management of RB is to save life. Salvage of the organ and function are the secondary and tertiary goals respectively. The management of RB needs a multidisciplinary team approach, including an ocular oncologist, pediatric oncologist, radiation physicist, genetist, ophthalmic oncopathologist. Conservative tumor destructive therapy to salvage eyeball is indicated when tumor involves less than half of retina and optic nerve is not involved. Present recommendations for the treatment are primary systemic chemotherapy for chemoreduction, followed by focal therapy for consolidation. The standard dose of CVE regimen recommended consists of 3 weekly 6 cycles of CVE, that is carboplatin, vincristine and etoposide. Depending upon the location and size of the tumor, focal therapy can then be chosen from the following modalities. Cryotherapy is indicated for a small tumor located anterior to equator. Laser photocoagulation is used for a small tumor located posterior to the equator. Thermotherapy with diode laser is used for small tumors located posterior to equator away from the macula. Plaque radiotherapy is very useful against localized vitreous disease and for the elevated tumors when laser is ineffective. External beam radiotherapy is now reserved for diffuse disease in the only remaining eye. The picture on the left side shows a peripheral retinal tumor that underwent cryotherapy. On the right side, the tumor has completely regressed, but the scar is much larger than the tumor itself. Plaque brachytherapy involves placement of a radioactive implant on the sclera corresponding to the base of the tumor to transsclerally irradiate the tumor. Commonly used radioactive materials include ruthenium-106 and iodine-125. Enucleation is the treatment of choice when the tumor involves more than half of the retina, the optic nerve is involved and glaucoma is present and anterior chamber is involved. Eyeball should be enucleated along with maximum length of the optic nerve. taking special care not to perforate the eyeball. Steps in enucleation surgery in brief. First is conjunctival peritomy. Then Tenon capsule is separated from the underlying sclera. The lateral rectus is hooked and the muscle is cut from the sclera. The enucleation scissors are passed around the sclera to the optic nerve. Then the enucleated globe is removed from the socket. The Tenon's capsule is closed over an implant. Tenon and conjunctiva are closed and a conformer is placed behind the eyelids. The picture on the right side is an enucleated globe with optic nerve involvement. Note that the proximal portion of the optic nerve is thickened, indicating tumor infiltration. Palliative therapy is given in the following cases where prognosis for life is dismal in spite of aggressive treatment. Retinoblastoma with orbital extension, retinoblastoma with intracranial extension, and retinoblastoma with distant metastasis. Palliative therapy should include combination of chemoradiation, that is CVE regimen, surgical debulking of the orbit or orbital exenteration, and external beam radiotherapy. The overall mortality is 15 to 20%. Mortality is higher in involvement of optic nerve, choroid, if it's poorly differentiated, or in large size tumors. Follow-up is extremely important. The rule is every 4 months until 3 years, every 6 months until 5 years, and every year for the next 3 years.